Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 14th topic. Occlusal plane. 14. Occlusal plane. Contents. 1. What is occlusal plane? 2. Spies curve. 3. The relationship between the Spies curve and masticatory function. 4. Wilson's curve. 5. Normal occlusal plane. 6. Abnormal occlusal plane. A. Part of the molar occlusal surface protrudes from the occlusal plane. B. The mandibular eighth tooth protrudes. C. Abnormal height of the molar occlusal surface. D. Reverse curve occlusal plane. Summary. 1. What is occlusal plane? The occlusal plane is a plane obtained by connecting the incisal edges of the incisors and the cuspal tips of the posterior molars. As shown in the illustration on the right, the occlusal plane is not a flat surface but a curved surface formed by averaging the occlusal surfaces of the teeth. Therefore, Dawson proposed referring to the occlusal plane as the occlusal curve. The occlusal plane is composed of three curves: the anterior curve, Spies curve, anterior-posterior curve of the molar region, and Wilson's curve, lateral curve. The anterior curve is determined by the aesthetics of the maxillary dentition and requirements for anterior guidance and articulation. The anterior curve will be explained on another occasion. This time, we will explain Spies curve and Wilson's curve. 2. Spies curve. Spies curve is a longitudinal curvature of the occlusal plane, as shown in the illustration above right. It begins at the cusp of the mandibular canine, connects through the buccal cusps of the premolars and molars, and extends to the anterior margin of the mandibular ascending ramus. Tracing this curve further posteriorly, ideally, it reaches the mandibular condyle, as shown in the illustration below right. The radius of this curve is considered to be approximately 4 inches on average. 3. The relationship between the Spies curve and masticatory function. As shown in the illustration above right, the long axes of each mandibular tooth largely coincide with the arc of each tooth's trajectory during closure, centered on the mandibular condyle. Consequently, the mandibular teeth can withstand functional loads to the maximum extent. The tooth axes of the most posterior teeth become more strongly inclined compared to the anterior teeth. Furthermore, this curvature relates to the condylar path during mandibular protrusion. As shown in the illustration below right, if the occlusal plane lies on an arc passing through the condylar head, even if the guidance path for the mandibular anterior teeth is flat, the inclination of the condylar path angle allows the molar occlusion to disengage. From the above, it is evident that Spies curve has a profound relationship with masticatory function, particularly mandibular protrusion. 4. Wilson's curve. Wilson's curvature, as shown in the illustration above right, is a curve formed by connecting the buccal and lingual cuspal tips of the left and right molars on the frontal plane. This curvature is established because the lingual cusp of the mandibular molar is lower than the buccal cusp. Consequently, the mandibular molars incline inward, while the maxillary molars incline outward. This inclination serves two purposes. First, as shown in illustration A on the lower right, The longitudinal axis of the molar region aligns with the direction of contraction of the medial pterygoid muscle. By aligning the maxillary and mandibular molars with the primary direction of contraction of the closing muscles, resistance to external forces is generated in the molars when masticatory force is applied. Second, as shown in illustration B below right, the lingual inclination of the mandibular molar occlusal surface allows food bolus to be transferred to the occlusal table, without interference from the lingual cusps of the mandible. Furthermore, the buccal inclination of the maxillary molars enables food bolus located on the buccal side to be transferred onto the occlusal table via strong contraction of the buccal muscles. From the above, Wilson's curvature is deeply involved in the resistance and chewing capacity of the molars. 5. Normal occlusal plane. When viewed from the side, the normal occlusal plane forms a concave curve, as shown in the illustration on the upper right. This curve is necessary for the mandible to move smoothly in the anterior-posterior direction. Next, when viewed directly from the front, the occlusal plane of normal molars forms a gentle concave curve, as shown in the illustration on the lower right. This curve is necessary for the mandible to move smoothly in the lateral direction. 6. Abnormal occlusal plane. As shown in the diagnostic model on the right, an abnormal occlusal plane can result from careless occlusal adjustments, improper prosthesis placement, inadequate occlusal surfaces on implant-supported prostheses, or discontinuation of orthodontic treatment. Abnormalities in the occlusal plane include several types, as listed below. A. Part of the molar occlusal surface protrudes from the occlusal plane. B. The mandibular eighth tooth lower molar protrudes. C. Height discrepancy between the left and right molar occlusal surfaces. D. Reverse curved occlusal plane. Each will be explained below. A. Part of the molar occlusal surface protrudes from the occlusal plane. As shown in the illustration above, the occlusal plane may become disrupted due to a portion of the molar occlusal surface protruding partially. This protruding area impedes the smooth anterior, posterior, and lateral movement of the mandible, contributing to functional malocclusion. This functional malocclusion induces strong teeth grinding, placing chronic stress on the muscles and temporomandibular joint, leading to various disorders. B. The mandibular eighth tooth lower molar protrudes. The most common type of occlusal plane with partially protruding molars, as shown in the illustration on the right, involves a bridge supported by the mandibular third molar, where the eighth tooth portion protrudes from the occlusal plane. In this case, no abnormalities are observed in the occlusal contact position or centric relation. However, as shown in the illustration on the lower right, when the mandible is moved forward, the protruding portion makes strong contact, preventing the anterior teeth from making contact. As a result, the front teeth become unable to bite through noodles. To resolve this malocclusion, strong teeth grinding during sleep is induced. C. Height discrepancy between the left and right molar occlusal surfaces. As shown in the illustration above right, the height of the occlusal surfaces of the left and right molars may differ. Possible causes include opposing tooth overjet following molar extraction, placement of prosthetics with improper occlusion, failed occlusal adjustment, or improper height of implant-supported prosthetics. Leaving this abnormal occlusion untreated for an extended period can lead to various complications. Determining height discrepancies in the occlusal surfaces of the left and right molars is based on a virtual line connecting the left and right temporomandibular joints. This abnormality cannot be detected solely through an examination of the teeth or by analyzing diagnostic models. As shown in the illustration below on the right, it can be confirmed by evaluating the relationship between the temporomandibular joints and the dentition using a face bow and models mounted on a semi-adjustable articulator. D. Reverse curved occlusal plane. The normal occlusal plane exhibits a gentle concave curve. Conversely, the reverse curve occlusal plane, when viewed from the side, displays a convex curve as shown in the illustration above right. In this state, normal mandibular movement is impeded when moving the lower jaw forward and backward. Viewed directly from the front, a reverse curve occlusal plane exhibits a convex curve, as shown in the illustration below right. If the lingual cusps of the mandibular molars are excessively high, they make strong contact when the mandible moves laterally, preventing the anterior teeth, especially the canines, from making contact. Consequently, this induces strong teeth grinding, causing various disorders to the muscles and temporomandibular joints that constitute the masticatory system. Summary. Morphological abnormalities of the occlusal plane are related to the functional movement of the mandible. That is, when an abnormality is observed in a patient's occlusal plane, it is possible to predict the presence and type of functional malocclusion. The final determination of whether the occlusal plane is appropriate should not be based on its ideal morphology, but rather on the functional abnormality identified through occlusal analysis. Furthermore, confirming the morphological characteristics of the occlusal plane during the initial examination at the first visit is extremely important. Understanding the morphological characteristics of the patient's occlusal plane enables prediction of the presence and type of malocclusion, providing crucial information for selecting the necessary examinations and tests required for occlusal analysis. Standard occlusion theory for TMD. 14. Occlusal plane is now complete. If you enjoyed this topic, please click the like button. If you have any questions or concerns, please write them in the public comment section below. The next topic is the 15. Theory of vertical dimension.